So good afternoon to everyone. I'm Luciano Saso. I'm a professor at the Faculty of Pharmacy and Medicine of Sapienza, University of Rome, which is a large university in Italy. A very warm welcome. I'm very pleased to see you all here at this session on building the capacity of healthcare workers providing care to refugees and migrants. I'm also a member of the Executive Committee of the M8 Alliance. The M8 Alliance is an association of universities, academic health centers, and the national academies based in Berlin, in Germany, having members all over the world. There are about 30 very prestigious centers, members of the M8 Alliance, which is very often referred to as the backbone of the World Health Summit. And we organized several sessions on the topic of migration and health in the last few years, also with some of the colleagues here with me today, in different countries, because as you might know, the World Health Summit takes place once per year in Berlin, in mid-October always, and then we have so-called regional meetings in different parts of the world. And when we say regional, we mean, of course, a big region like this one, South Pacific. It's a great pleasure for me to be here today. Before starting, let me also acknowledge the country. Together with all the other panelists of this session, I would like to acknowledge the traditional owners of Narm, the peoples of the Kulin nations on whose country we gather for this event. We pay our respects to their elders, past and present, and to the elders of all First Nations communities that are joining us here today. We undertake to work together with respect with Aboriginal and Torres Strait Islanders peoples, communities, and organizations in a shared journey to better health. We recognize the ancient and diverse cultures of Australia's Indigenous peoples and strive to consider them in our quest for health equity for all. And now it's a great pleasure to introduce the panelists of this session. We have a very distinguished lineup today. With Dr. Santino Severoni, Director of the WHO Health and Migration Department in Geneva. Unfortunately, he could not travel to Australia on this occasion, but he sent us a video that we will screen in a few moments. Professor Joachim Seibold, Deputy Medical Director of Charité University in Berlin, in Germany. Professor Amir Hossein Takian, Director of the Department of Global Health and Public Policy, Vice Dean of the School of Public Health, Tehran University of Medical Sciences in Iran, Dr. Kuzai Kanutu, Dean of the Royal Australasian College of Physicians in Sydney, Australia, of course, and Dr. Sharuna Verghese, Senior Lecturer of the Jeffrey Chia School of Medicine and Health Sciences at Monash University in Malaysia, Subang Jaya, Malaysia, and Dr. Shieza Malunga, Team Leader of the Monash Health Refugee Health and Wellbeing in Dandenong here in Australia, and Professor Stephen Matlin, a Visiting Professor in the Institute of Global Health Innovation at Imperial College London in the UK. So without further ado, I would like our technical support to screen the video, please.
Ladies and gentlemen, dear colleagues, I'm pleased to present you the WHO Global Competency Standard for Refugees and Migrant Health that we are at the moment implementing worldwide. Refugees and migrants may face a number of challenges to accessing health care, including language and cultural differences, institutional discrimination and restriction use of health services, which shape their interaction with the host country's health system and health workforce. At the same time, refugees and migrants often have health needs that might differ from those of host population due to the impact of migration on physical and mental health. Socioeconomic inequalities experienced by refugees and migrants are further exacerbated by exclusionary policies and inequitable access to employment and education opportunities, and have a significant influence on health. The health workforce has a vital role in providing people-centered health services and building the resilience of health systems to respond to the health needs of refugees and migrants. These require health workforce with specific competencies. Several guidelines trainings have been developed by WHO over the years for healthcare workers, such as code of conduct and others. However, guidance was lacking on the critical aspect of competent health workers who are trained, supported, and empowered to provide quality people-centered care to refugees and migrants. Additional evidence on the critical need of having health workers trained, supported, and empowered to provide quality people-centered care to refugees and migrants is emerging from the work we have been doing at the country level, specifically all the refugees and migrant health systems reviews, which under the leadership of the local Ministry of Health, look at the opportunities for strengthening across the health systems blocks and essential public health functions we have conducted so far, such as Jordan, Uganda, Czechia, Bulgaria, and Thailand, and all of them, they have highlighted the need to reinforce soft skills of healthcare workers with focus on competency standards. Let me give you some details. The standards aim to support a competency-based outcome approach to education and training for health workers who provide service to refugees and migrants. This could include in-service and pre-service training. Competency-based education situates knowledge and skills in two specific contexts of practice. In this case, refugees and migrant health, while recognizing that the composition and responsibilities of the health workforce are also shaped by the specific health systems and health practice of regions and countries. Based on the above-mentioned items, it guides the development of a curriculum to train health workers to meet the demand of current and future practices in relation to refugees and migrant health. In consideration of the ongoing work around strengthening capability of health workers to provide culturally responsive and effective care to migrants and refugees population, the WHO Department of Health and Migration started a collaboration in 2021 with the Migrant and Refugees Health Partnership, auspiced by Migration Council Australia and the Australian National University to develop the global competency standard. The process of developing the standards was intense and informed by a multi-country review, mapping health systems, responsiveness to refugees and migrant health needs in 18 countries, and an extensive literature review analyzing the common health needs and barriers to accessing health care. Simultaneously, the work on the global competency standard built upon and aligned with the existing WHO Global Competency Framework for Universal Health Coverage, done by the WHO Health Workforce Department. The process was further informed and guided by the technical evidence provided by the Strategic Working Group, which was made up of experts in refugees and migrant health. The Strategic Working Group reviewed the draft standards to ensure its relevance and applicability for health workers in different settings and countries. Additional consultations were also conducted with an expert group drawing from universities, UN agencies like International Labour Organization, UNHCR, UNICEF, IOM, and others, and non-governmental organizations. Important was, in fact, also to consult the civil society. The final product, what we call the standards, was organized into 5 domains with a series of competencies and behaviors which each domains. For instance, domain number 1, person-centeredness, which is a competency number 1, includes the behavior of addressing mental health and the psychosocial support needs of refugees and migrants by providing trauma-informed care and intervention sensitive to experiences of chronic hardship, traumatic event, grief and loss, facilitating referrals. The same domain 1, under the competency number 2, include the need of assessing the person's health literacy and health systems literacy, including identifying area of strength and specific area of risk. Additional competencies and behaviors under the following domains are critical for the health workers. Domain 2 on communication, domain 3 on collaboration, domain 4 evidence-informed practice, and domain 5 personal conduct. Example of them includes domain 2 on communication, competency 3, engage safe and appropriate aids to meet language and communication needs of refugees and migrants. Under the competency 4, supports refugees and migrants to understand information about their healthcare. To support the operationalization of the standards, the knowledge guide and the curriculum guide were developed in line with the standards. Let's explain a bit the knowledge guide. The knowledge guide is designed for educators and health workers to assist in designing or integrating learning content to apply to the standards in practice. It details the learning outcomes that reflect the behaviors that a health worker will demonstrate once they have achieved the competency standards, and examines how a health worker's knowledge, skills, and attitude can reach the stated benchmark for providing people-centered health service to refugees and migrants. For each competency standard, the knowledge guide sets out the knowledge, attitude, and skills and learning outcome that will be relevant for health practitioners and health administrators. Let's look at the curriculum guide. The curriculum guide provides guidance for institutions, health organizations, and individuals engaged in the education and training of health workers to outline options for developing curriculum material using the learning outcomes set out in the knowledge guide. The curriculum guide recognizes the many contexts in which health workers provide health service for refugees and migrants, and provides a flexible template for designing curricula that can be integrated into pre-service training or used for targeted modular in-service training for health practitioners and health administrators. WHO aims to operationalize these standards across key modalities such as pre-service education by mainstreaming the competency standard package into curriculum and learning outcome which selected university training programs, and in-service training by developing and adapting courses for policymakers and healthcare workers at country, regional, and global level utilizing existing platforms. Last but not least, training program through the Open WHO will allow develop and using the material developed for e-learning courses. And the following slide will provide key current examples. WHO recently started the implementation at country level by providing in Nigeria a one-day orientation course to policymakers and health managers that in 3 days intensive capacity building to healthcare workers. The National Federal Ministry of Health is planning to further tailor the competency standard and extend it to all states. Similarly, capacity building sessions are being planned for various West African countries, such as Senegal and Nigeria. WHO is currently working with the National Institute for Health, Migration and Poverty in Rome to pilot the first global training, which will consist in bringing once or twice a year policymakers from different countries and regions for orientation and knowledge on the global competency standards. The augmented perception around the critical need of strengthening healthcare workforce is further validated by the fact that various institutions worldwide, in example, Harvard, are working on tailoring the WHO standard to their local needs. WHO is also finalizing the e-learning course to accessible by all in Open WHO platform. Additional initiatives include, for instance, the current adoption of the competency for cultural mediator in the European region. To conclude, we would like to present a short extract of the video course designed for the workers in Ukraine and neighboring countries to Ukraine a few months after the onset of the current war in Ukraine, in collaboration with the Australian Migrant and Refugees Health Partnership. The course is specifically devised for workers who might be time limited and operating under high pressure environments. It is a 30 minutes video that familiarizes viewers with a global competency standard for health workers in a targeted, succinct, and engaging manner, and equips you to consider how the competency standards might be applied in the course of everyday health service provision. The purpose of the course, delivered in a video format, is to support health workers by demonstrating how the global competency standard can be adopted and applied in a real setting, in this case to migration and displacement from Ukraine due to the war in that context. Let me show you a short promo, a few seconds, and the page of the website, WHO website, where the trainings are available as an open source. This is the page of our website, open for everybody. You need only to enroll to the course, which is about 30 minutes. And let me share with you, to conclude, a short promo of the work we have done for healthcare workers, particularly in the neighboring country to Ukraine, which have been hosting millions of displaced population due to the war. Thank you very much.
Thank you very much to Santino Severoni for this video.
I thank you and wish you good continuation of your work.
Thank you, very, very useful. So now we continue with the panel. So I really, as the panelists already know, we try to keep the time in order to leave at the end of this session enough time for discussion. So I kindly ask everyone to try to speak not for more than 5 minutes. And we will follow this first order for the first round. So we start with Joachim Seibold, as I said before, is the Deputy Medical Director of Charité University in Berlin.
Thanks, Luciano, for the introduction and also for bringing us together here on stage and in the room. When we started our work with refugees seeking for asylum in the state of Berlin, we faced different challenges, quite new for us. A university hospital which has been around for more than 300 years with an experienced workforce of to date 22,000 employees, including 3,500 doctors and 4,500 nurses. But we made quite new experience and had to build first up immediate help within days in different refugee shelters, as there was very limited access to the regular healthcare system for unregistered refugees at that time. For the patient in the shelters with mostly mild diseases, we found colleagues from many different departments in our hospital who volunteered. We conducted in this early phase an observational study which showed that most of the patients required rather a type of family medicine practitioners. Subsequently, we replaced our physicians with very different medical background because they were from different departments working part-time, and we replaced them in our workforce by a stable team of full-time doctors and nurses dedicated only to migrant health on a daily basis. In the next step, we established a health screening clinic for all incoming refugees seeking for asylum in the state of Berlin, which included vaccinations. For this more generalist work, we train our staff regularly and even edit a 300 pages textbook, most of them with authors from our own university hospital. We give them essentials to diagnose and treat the common diseases and to identify rare diseases among migrants. Currently, the colleagues of my team see about between 50 and 120 asylum seekers per day newly arriving in our state. This health screening clinic also offers a platform for research on the situation and needs of refugees. For example, we have done 2 observational studies on mental health needs for adults and for children, and also studies on different aspects of female genital mutilation. Following the immediate activities in the shelters and the health screening clinic, more specialized medical services were needed, particularly for vulnerable patients, such as mental health service for adults and children, pregnant women, chronic infectious diseases, etc. As mentioned earlier, we established a central clearing clinic to provide mental health services for refugees. This required a well-trained, multidisciplinary workforce as well as excellent translator, both we hadn't had before. Within the first 18 months, we saw 3,096 cases with 63 different nationalities, speaking 36 languages. The most frequent diagnoses were unipolar depression, about 40%, post-traumatic stress disorder, about 24%, and adjustment disorder, about 20%. What was thought to be a clearing clinic for screening turned out that mental health diseases were diagnosed in this patient group in more than 90% of the referred refugees, probably because of the urgent need and the easy access, no health insurance required, no registration, free of costs. On the other side, it was not easy to establish a stable mental health team of nurses and doctors. For example, we found only 2 psychiatrists with native speaker competency in Arabic, though we found nurses and social workers with Farsi competence. In addition, we had to accept that our child and adolescent psychiatrists needed more time to recover from what they have heard and experienced during the consultations. Even though we provided much support and supervision, as well as additional holidays, we were told that the high frequency of new patients, rather than continuous work with a fewer number of patients, was the reason of increasing exhaustion. To summarize from our experience, early phase volunteer healthcare workers in refugee and migrant health are important and provide often the fastest help, particularly when it comes to public health crises. Transferring this early phase volunteer healthcare team into a full-time and stable team of professionals with the necessary capacity is crucial. These teams need standards and continuous learning support. What is also important to avoid discouragement of the staff is easy access to various specialists, ideally in the same institution. These specialists, such as psychiatrists, have ideally native speaker competence and can be supported by video links for particular languages. Telehealth can be very valuable. We are going to hear that later. A very valuable option to involve specialists. Finally, we do experience a shortage of nurses in Germany and, of course, also in our hospitals. But fortunately, not in the field of medical service for migrant and refugees. Thank you very much.
Thank you, Joachim. Now we proceed again with Amir Hossein Takian, Director of the Department of Global Health and Public Policy, Vice Dean of the School of Public Health in Tehran, University of Medical Sciences in Iran.
Thank you very much. Good afternoon, ladies and gentlemen, and thank you, Monash, and thanks, Luciano, for bringing us together. Santino made my life much easier. I'm stating some things which you know for fact, and then at the end of my 5-minute intervention, I bring some experiences from Iran to see how we can actually integrate the services for refugees into the mainstream health services. The first thing is, this year, just a couple of days ago, WHO motto is "My health, my right." And we shouldn't forget that my health, my right is including refugees' health and refugees' right to have health. That's the first thing. The second thing is, in the course of last decade, the World Health Organization has been advocating universal health coverage as the pillar, as the main objective of the health system. And in context of countries with huge number of refugees, universal health coverage is not achieved without refugees' health. And that's include my home country. And the third thing is, out of over 110 million forcibly displaced people who live in different contexts, 2/3 of them are located in low and middle income countries. And my own country itself, out of 110 million, we host about 9 million Afghan refugees whose number has just doubled in 1 year and tripled in 2 years since 2021 after the change of regime in Afghanistan. So you can see that the country of 90 million population, almost 10% of the population has been added just in 2 years' time, and those, the majority, has no legal status. They are across the country, there is no shelter, only 2% of them are in the camps, and that's why this is our responsibility to do that. Santino said something about the global competency standard framework, which is very, very important and helpful in order to organize for refugees' health and workforce. One thing to consider, and it's very important, is, first of all, refugees are human beings. So they have their own needs like all the citizens. And the second thing is, they have been subject to discrimination, subject to vulnerability, and some of them specifically, like pregnant women, like children, like the one who have been trafficked into the country, like the one who have no employment status or legal status, specifically in the context of my home country, the majority has this condition, are in much more severe conditions. And mental health and physical health both, and specifically mental health, is something which matters. In my context, we speak Farsi. So Afghan refugees, the majority of Afghan refugees who cross the borders from the east to the country, they speak the same language. But you know what? Because of the fear of deprivation and the fear of deportation and this kind of stigma which comes with them, so the majority, even though they speak the same language and they don't have any language barrier, they don't come to seek health. So that's why, specifically during COVID-19, when we had all of these refugees embedded in the society, we had a big challenge to identify, to trace the cases, and some of them come with some diseases like multi-drug resistance, TB. Some of them come as the kind of teenage pregnancy and this kind of thing, which adds to the burden of that. So my point here is one. When we adopt mainstream services, which we have done in my country, rather than focus, especially focused services, which some countries do, and when those refugees are within the society, not in the camps, we need to somehow foster some mechanisms in order to reach out those refugees with the limited workforce that we have. And for that, I think what the competency framework says, which is very important, is using the refugees' workforce themselves, even with little training, in order to somehow materialize the provision of services for them. And for that, out of 5 domains that Santino said, we have adopted all of them, and specifically when it goes to collaboration, which is domain number 3, something which is very important, I would say fundamental, is social determinants of health. Because the majority of these cases are affected by the social determinants of health, including the income, education, access, barriers, discrimination, and these kind of things. And for that, what we have done is the government of Iran, and specifically in collaboration with the civil society, we have established some organizations, charity organizations, which is led by refugees for refugees. Just one simple example, in the south of Tehran, which is under the coverage of my university, and it is a deprived area, there is one organization for mental health counseling for refugees. What we have done is the municipality of Tehran has established a center, so we have given the space to the refugees, and we have somehow called upon refugees with some specific training on mental health issues. Because we have been training Afghan doctors in the course of last 30 years, even we have some Afghan specialist psychiatrists within the country and psychologists as well. So this center, to avoid and prevent any discrimination, language barrier, and this kind of things, is led by Afghans for Afghans. And there are some nurses and volunteers helping them. So in the course of last 5 years, this center has reached out over 20,000 Afghan refugees suffering from different things, different aspects of mental health. In addition to that, we have trained some volunteers, and specifically women, who goes to the community and provide this care. That's the first example. The second example is in 2017, actually in collaboration with the government of Italy, was very generous. What we did, we went to the government of Italy and secured €1 million fund. What we did in collaboration with UNFPA and Tehran University and the Ministry of Health in Iran and the Ministry of Interior, we established a maternity ward for Afghan refugees within the facilities of one maternity hospital in the south of Tehran. That is because, unfortunately, even back in 2017, before the change of regime in Afghanistan, Afghanistan has the highest maternal mortality globally. And one of the reasons for that is the lack of a skilled workforce. What we did, we went to Kabul University, we strengthened the capacity for midwifery, we identified ourselves through our faculty member. I traveled to Kabul because I was the coordinator of the project. I traveled to Kabul and we identified 50 girls from Afghanistan, 47 for bachelor and 3 of them for master of midwifery. We took them to Iran. We trained them, and then the Minister of Public Health in Afghanistan visited the facility and we made a contract, and those girls were responsible to go back to their home country and serve the community, that is for 2 years. And in this capacity, we started to somehow strengthen the capacity of midwifery in Afghanistan, which proved to be very, very important and productive. Unfortunately, the change of regime somehow diminished that. And the last example, and I finish with that, COVID-19 happened. At the time, we had 3 million. When COVID-19 happened, the first cases was identified in February 2020. Then we did have almost 3 million Afghan refugees, 1 million documented, 2 million undocumented. Then we immediately realized that some of the majority of those Afghan refugees, they don't follow the restrictions, they don't follow the vaccination when the vaccine came and things. What we did within our primary healthcare system, which is very comprehensive in rural areas, again, we asked for Afghan volunteers to go and train these refugees and their families and the children and within the school and things in order to somehow encourage them for coming for vaccination. Teach them how to do the social distancing. And after the, say, 6 months, we hired some, we paid to them to be established specifically in some cities, because in 8 cities in Iran, we have a kind of dense population of Afghan refugees. Those are designated cities. And with that, we managed to actually reach the vaccination rate similar to the Iranian citizen for Afghan refugees and countering this. And these services through PHC continued. And I'm so pleased to say, despite all odds, Iran is under huge sanction, we are running out of our workforce, we don't have enough money and this kind of things. But you can imagine, when you adopt the mainstream services for those refugees, then in order to reach them out, you need to somehow have those refugees with skills and with education and train them, some specific training. For instance, in my university, we have designed a 6-day course. And with that 6-day course, we somehow strengthen the capacity of skilled workers, Afghan skilled workers, to go to the community and provide PhD services. And we continue to do that. And we hope that with this kind of integration, we can address the refugees' health needs. I'm more than happy to take questions, any. Thank you. Thanks, Oshana.
Thank you, Amir. Now it's a pleasure to continue with Kudzai Kanutu. As I mentioned, she is the Dean of the Royal Australasian College of Physicians in Sydney. Please.
Good afternoon, all. Thank you both for sharing your reflections. And I think it reminds me of the value of these types of forums for sharing and understanding how a curriculum like this actually works out in clinical practice and in a health system setting. What I hope to do with sharing my reflections is to provide you with some of the Australian context of how refugee and migrant health transpires within what is a publicly funded health system, but by virtue of its age and the way that it is funded, also has its quirks and I think poses some challenges in terms of how a curriculum like this can actually translate to meaningful impact. As somebody who works in health and medical education, I was also reminded of that central tenet of medical education and education as a whole, which is that evaluation or assessment actually drives learning. So I think one other piece, and I'm really gratified to see that there is an implementation guide or a knowledge guide that actually goes with the curriculum guide to guide people around how they can translate what is a paper document into meaningful change. I wanted to share two case vignettes or recent examples of some clients that I've managed in my clinical practice to give you a picture of how it actually happens on the ground. I'll start with a clinic that I ran last week. And one of my clients is a gentleman who is again a humanitarian entrant who has been in the country for over 20 years. He is in many respects, and you will concur with this, complex on many levels. History of mental and physical trauma, ongoing, I think, psychosocial trauma with respect to the way that he has been integrated into Australian society or failed to be integrated into Australian society. On this particular day, the first thing that struck me was that his name actually appeared as having arrived for that clinical engagement, because it was frequently the case that he was somebody who was often failed to attend, arrived late, missed appointments, and one that I think many within our clinical team were starting to think of as being a bit of what they call the heartbreak patient, the heart sink patient, where we think, oh boy, we're just not getting anywhere with this particular gentleman. But there he was, he'd arrived, not only arrived, he was there 20 minutes early. So I went into the waiting area to find him. He was there with his case manager. And I actually took a step back when I saw the man that was in front of me, dressed immaculately, normally very withdrawn character, a whisper of a person. And he came towards me with the biggest smile I think I've seen on any one of my patient clients for a long time. And I thought, I have this point of clinical narcissism where I think, it's me. I finally managed to turn this gentleman around, and he's finally starting to turn up and engage. As it turns out, the critical difference was that he had finally managed to see a dentist and had his teeth back. This is a gentleman who had been in our health service for over 12 years, had been in the country for over 20, and had had no teeth for 24 years, so a quarter of a century. And the difference that it made for him actually finally seeing a dentist and having that addressed as he's really a rate-limiting piece of his clinical care was the thing that had changed him from being somebody who was not attending, to somebody who was actually starting to actively engage, because it meant that he could access many of the services that we had previously recommended he attend and not feel as though he was not welcome or was frightening to children and to a place. And we had this conversation and emerged that was the central difference. The reason I share that story is because I think one of the challenges we have around actually evaluating and assessing that translation of curriculum into meaningful change for clients is that we often don't actually ask our clients, what is it that you feel is the most critical piece of your clinical care? We often get quite obsessed with our particular piece of that patient's care, and then we also don't pause and reflect on how we evaluate the team-based efficiency. And I hope that this would be a moment for us to reflect on how we evaluate team-based competencies and team-based efficiencies, because each of us, and I would say this of this particular centre where I work, are phenomenally good as far as culturally inclusive care. Everybody is very embedded in it. We always have interpreters, and if we don't, there is always a plan B, C and D. But somehow, in our individual excellence, we had failed in addressing a central piece of this man's care that was actually presenting a significant barrier to fixing his care comprehensively and allowing him to engage. So where is that space where we actually evaluate team-based efficiency, and how do we set team-based goals, especially when, as we know, people will often be navigating between multiple health services where the team is profoundly distributed. The competencies are variable across those teams, and how would we actually work to evaluate and that performance against that? The second vignette we'll actually do my last one for this series of conversations is the patient that I had in the afternoon, who was a woman who had arrived only 5 years ago. She was born in Myanmar, but like many people of humanitarian entrants from that region, had lived in Malaysia and in other countries prior to arriving. She had then proceeded to move between states and locations across Australia to finally arrive back in Melbourne after having moved around. So the question she had was, she was seeing somebody for her hepatitis B care in Western Australia, and she wanted us to know what had happened with her while she was there. We had an awful time trying to get notes back and forth from the multiple places that she'd been, and really arrived at a point where we were starting from scratch. And I raise this because I think the other piece of evaluating the feasibility of curriculum implementation is the context, and in particular the digital infrastructure that supports that curriculum implementation. We can be as effective as we want to be, we can be as inclusive, as patient-centred as we want to be, but when we have somebody who cannot access their information and also has no feasible means of reconstructing their clinical journey from the time before they arrived in Australia to the first visit, and then through to that point of care, we will really struggle to implement any of this curriculum, and we'll also struggle to encourage people to be proactive, and it's something that I feel we really need to call out. So I'll stop there on the point of that team-based evaluation of curriculum implementation, and also the digital infrastructure that actually supports us to be as effective as we want to be in support of engaged and empowered patients. Thank you.
Many thanks, Kudzai. Now it's a pleasure to leave the floor to Sharuna Verghese, Senior Lecturer of the Jeffrey Chea School of Medicine and Health Sciences at Monash University in Malaysia.
Thank you, Luciano. Good afternoon, colleagues. In this round, I want to focus on the broader political and legal context which guide the migrant and refugee healthcare in many destination countries in Asia, and a little bit on what we are doing for refugee health in my country, which is Malaysia. So looking at the broader context, political and legal, in most destination countries with regard to labor migrants and refugees, we see that health systems are having to navigate a very complex terrain of migration politics, where health systems and health policies are being instrumentalized to regulate migration flows. So if you look at labor migrants, for example, we see that pre-employment medical fitness tests are bringing the healthiest and the fittest of especially young people from the more poorer countries in Asia to the more affluent destination countries. And yet, when they come, the whole migration policy framework is so incoherent that it not only affords no protection, whether in terms of occupational health or safety, labor rights, access to redress, any of their rights, the social determinants of health, but actually migration policies put them in harm's way, putting them at risk of disease and injury. And yet, when they fall ill, especially with treatable infectious diseases like tuberculosis, for example, they are deported. Even pregnancy is terms for deportation. And so if they have borrowed, thousands of dollars to finance their migration journey, they're actually going back impoverished and steeped in greater debt. We also see that there are healthcare policies in countries like Malaysia where healthcare workers are required to notify immigration authorities if there are undocumented migrants within the hospital services. And although this is not consistently practiced, it is a deterrent and it leads to them avoiding healthcare, but it also creates challenges for healthcare workers, like the ethical dilemma of dual loyalty. And then we also see, and this is an emerging trend in many countries in Southeast Asia, also the Middle East, the GCC countries, of the withdrawal of government subsidies for non-citizens, and this trend of compelling them to purchase private medical insurance and to seek healthcare in the private healthcare sector. And so what this means is also that there is this shift from a collective risk sharing to an individual risk management. And we know from healthcare financing that the principles that guide these two approaches are actually quite different. And so it has really serious consequences for inclusion, for equity, and it therefore begs the question, how universal is universal health coverage? And COVID-19 actually exposed these already pre-existing inequities in countries like Malaysia, even though the Ministry of Health practiced vaccine equity and generally had equitable policies. Because of the mass arrests that the Ministry of Home Affairs had initiated, we saw that migrant populations were disproportionately affected. There were avoidable outbreaks in immigration detention centers because of the mass arrests that were taking place. When they were rounded up, they were sprayed with disinfectants as a way of supposedly controlling the transmission of disease. Non-citizens and migrants formed a third of the brought-in dead. And so this highlights not only the implications that these problems create for equity and inclusivity, but also the risks that healthcare workers themselves experience in providing healthcare. And within this complexity that's taking place and the challenges of the different transitions, epidemiological, demographic, all of that health systems have to contend with, health worker shortages, deficits in infrastructure, we are also seeing this massive privatization of healthcare and of medical education. And so what we're also seeing is this hemorrhage of specialists from the private sector, from the public sector to the private sector. We are seeing the mushrooming of medical schools all over, which is having consequences for the quality of medical education. Our public hospitals are bursting at the seams. And so when push comes to shove, and within this context of scarce resources, then citizenship becomes that mediating factor for deservingness to healthcare. So it's within this context, I just want to highlight 4 initiatives that are taking place in Malaysia in the realm of refugee health. We are focusing on building the capacity of non-specialists because of the dearth of resources and frontline workers, and because a lot of my work in the past 15 years has been in the area of mental health. With the colleagues in Malaysia, we are focusing on 2 areas specifically, building capacity to implement the MHPSS implement operational framework, as well as trauma-informed care, so that it's not only the health sector, but whichever might be the other sectors of education, gender, women, and so on, everybody is able to pull their weight in promoting the health and well-being of refugees. We're also focusing on the training of refugees as community health workers. There are different trainings. The NGO that I co-founded, we run a 9-month competency-based training, at the end of which they're able to identify signs and symptoms, make referrals, translate for therapy, provide treatment adherence support, and work in multidisciplinary teams. We're also focusing on strengths-based interventions, so training refugee teachers in integrating social emotional learning with refugee children, because we also, and also various other health programs related to infectious diseases, because we see that the refugee schools provide a very important entry into the wider refugee community. And finally, training both refugees as well as NGOs in facilitating support groups, because it has been our experience that it not only improves health outcomes, but for those who are socially isolated, such as single women-headed households and so on, it helps them to make those social connections, establishes and expands social capital, and also keeps them in remission when they're recovering from mental health problems. Thank you.
Thank you, Sharuna. And now it's a pleasure to give the floor to Shiaza Malunga, team leader of Monash Health, Refugee Health and Wellbeing here in Australia. Please.
Thank you, Luciana. So I'm going to talk from an angle of what actually makes a healthcare worker be able to deliver their healthcare service. So I work at Monash Health, which is a healthcare service in the southeast region of Melbourne, which operates on the traditional lands of the Bunurong and the Wurundjeri people of the Eastern Kulin Nation. Our service thrives, and I say thrives because we're a multidisciplinary team that provides on-arrival assessments for newly arrived refugees as well as people seeking asylum in Victoria, because we're working under a supportive policy and legislative framework. So looking at for people who know the Australian policy landscape, our policies are not really asylum seeker friendly. So people that are seeking asylum are excluded from the universal access to healthcare that was spoken of today in the first plenary. So people are in Australia living in this community where everybody else has got universal access to healthcare, yet they have no access to healthcare. But we're privileged to be under a state government that then provides bridging funding, which enables my team to do the work that we do. So I guess talking about some of the supportive pillars, the frameworks that have been developed both internationally and locally are important, but without policy and governments that actually support funding that enables the healthcare workers to do the job that they need to do, it is virtually impossible to do it. So I acknowledge the privilege that my team sits in. We're working in a supportive state government. We're working in a supportive healthcare system where we are based in a community health service, but are co-located with infectious diseases, pediatrics, and psychiatry within the same service. This gives us a superpower, which is very basic when you look from the outset. A mother with 8 children, and parents with 8 children, really, who might need to access pediatrics for 6 of those kids. They might need to access infectious diseases for management of their latent TB or hepatitis B, and they might need to access psychiatry. How many appointments do they have to attend? So having a system that is able to look at a family and say, they're coming in on Monday for a pediatric appointment with all the kids, is that the right day to put a psychiatry appointment for them? Should we book in their psychiatry appointment during school time when all their kids are in school, and then they can have the appointment that allows the clinician to focus on the patient in front of them? So our approach is not only about developing the clinician, but developing systems that enable us to deliver the work that we need to do. For any people in the room that have worked with someone who speaks another language, and working through an interpreter, you need double the time. Right. So I'm delivering 5 minutes of this talk, but if someone else was interpreting for me, which internally is happening because some words I'm thinking in my mother tongue and thinking, what does that say in English? It means it takes double the time to deliver the healthcare. So being in a system or in a healthcare service that allows us to do that means we can actually put all of those implementation documents, all of those frameworks, all the clinical practice into actual meaningful patient care. So while we talk about we need to work across systems to enable clinicians to be well-trained, we also emphasize the importance of that systems change. We emphasize the importance of knowing how to work with interpreters. No one likes additional training. So if in this conference they said to be able to attend, you needed to do an additional OHS training before you entered this building, no one would want to come. But when we put modules around refugee and migrants as add-ons, no one wants to do it because no one wants to work with an add-on. So the framework and the language that we use in our practice already says this is our bread and butter. Refugees and migrants are everybody's bread and butter because displacement is what is this century is all about. Whether it's international displacement, whether it's internal displacement. So some of the things that our team works on are looking at language, reviewing how we describe people that have moved from one place to the other, and ensuring that our baseline of delivery of care enables us to speak to the patient in the right language and using the right amount of time to deliver the care. So in terms of the work that we do, we take a really holistic approach to building the capacity of the sector. We are interested in making sure that the person who's working at reception in a hospital knows that a person seeking asylum is funded by our state government to be able to access healthcare. There's a lot of people who are the gatekeepers. So if the person who's working at a medical practice or in your hospitals at reception is not friendly, people are not going to come for their appointments. My fellow panelists have talked about different ways and different things that they've done to engage people, but I can tell you your front of house staff, if they are not trained, are going to be the reason why people do not attend and the reason why we are wasting funding when clinicians are in the room. So we take an approach that trains our front of house staff, our security. Anyone working within our service has to work from a trauma-informed approach, as well as acknowledging that the healthcare service needs to be responsive to the fact that people that are coming from traumatic situations don't only need a trauma-informed approach to their care, but also need people that have got the time to be able to provide that care. That's it from me.
Many thanks to shares as well. And now, last but not least, we have Stephen Matlin, a visiting professor in the Institute of Global Health Innovation at Imperial College London. Please, Stephen.
Thank you, Luciano. And I want to talk about the question of the need for integration of migration health aspects in the education of health professionals. And I hope this is going to work. Which way do I point this? Oh, okay. Got it now. Since I'm speaking last in this first cycle, quite a lot of what I'm going to say is going to turn out to be a summary of points that you've heard, but also I'm going to be trying to extend them and generalize them, but I'll also be pointing to a number of gaps that I think are becoming increasingly apparent. So a few years ago, I had the fortune to be invited by Luciano to take part in what would turn out to be the beginning of a cycle of M8 expert group meetings on migration and health, which he was establishing in Rome. And this particular meeting reviewed what was going on in the field of migration and refugee health, and it led to a publication in which we tried to draw together and identify gaps in migrant and refugee health and to point towards an agenda of solutions. And in the area of education and training, there were many gaps, and some of the key conclusions from that meeting and the follow-on publication were the need to incorporate migrant and refugee health into curricula of medicine and public health degrees, and also to launch specific training programs and expand the availability through what were then still, in many cases, rather experimental new techniques for distance learning in these fields, but of course with COVID have become absolutely standard now. And there was a need to train people within that broad medical training in the particular health problems of migrants and refugees, and an emphasis in that meeting on the need to develop cultural competence as well as technical skills in diagnosis and treatment. And reinforcing those conclusions, and particularly about gaps, a publication by WHO in 2022, its report on World Health Report on the health of refugees and migrants, placed some emphasis on the need to meet these health needs by integrated health systems and including the health of migrants and refugees within systems serving the host communities. And we've heard today how that, so to the extent that it is being implemented in some places, needs to be adapted in local contexts and with quite different sorts of approaches. It's also the case that surveys of health professionals in many parts of the world point to the fact they often feel insecure about their ability to deal adequately with people from migrant and refugee backgrounds and to provide them with the health care that they need. And complementing that on the side of the migrants and refugees themselves, to the extent that they're able to access health services and treatment, they often report much lower levels of satisfaction in their encounters with the health system than do the host population. They're more likely, if they have these encounters, to experience adverse safety events, And very often patient complaints are due to communication errors. So what's been, I think, very clear and has been illustrated again today by the various presentations is that there are particular health problems of migrants and refugees that the people trying to provide them with health support and care need to be aware of. And the risk to the health of migrants and refugees extends across the whole span of their experience, beginning before the migration process, when there are a whole range of biological, environmental, socio-economic and political factors that may influence their health and may be sometimes part of the reason that they're leaving. During travel, the particular experience of each individual migrant may have all sorts of factors in it that adversely affect their physical and mental health. And unfortunately, in the transit places where they may often spend very extensive periods of time, as well as in their final destinations, the way that they're treated or not treated can add further to the risks to their health. So it becomes clear that, as been referred to today, social as well as biological determinants of health are extremely important. And of course, migration itself is a determinant of health. 2 or 3 years ago, we had a further meeting which focused particularly in the M8 Alliance group on the education of health professionals. And a couple of points there that were highlighted in the context of mainstreaming migrant and refugee health were the need to include the social and political determinants, and that the health professional needed to have in their training some perspectives on the history, anthropology and human rights of people they might be encountering, and that there were challenges of operationalizing ethical principles that people believed in, and there's very strong emphasis on what is the perspective of the people being treated, what do they regard as their problems, difficulties and solutions. It was also emphasised in this meeting that the education and training could help to advance health equity in a variety of different contexts, including clinical, community level and political level. And there was quite a lot of discussion in this meeting on the group of things which I've called here the cultural competence, diversity and intersectionality nexus. And I want to just spend the last couple of minutes talking about those three together, partly because in the competency standards, which Severino was talking about at the beginning in his video, there is actually no reference to any of these three topics in the standards. There is talk about competence being needed, cultural rather. There's talk about cultural awareness being needed, there's talk about diversity being important, but there's actually nothing set in terms of what might be standards to apply. And so very quickly, cultural competence is, of course, about starting with establishing some cultural awareness, going on from that to deeper cultural knowledge, building cultural sensitivity, and eventually establishing through a combination of training and practice and reflection, real competence in being able to deal with culturally different people. And while there is now quite a lot of recognition around the world of the importance of cultural competence and a growing body of literature in regard to education and practice in health, there's been only modest progress in adapting these approaches, and it is not systematic and rather sporadic in where you find it. And there is generally an absence of agreed standards, both nationally and internationally, against which a sort of global competency framework could be established. So this is an area that still needs further work doing on it. And with diversity, again, there's a recognition in some places of the need to have diversity competent health professionals, the importance of including this, therefore, in their education and training, and of helping to span from cultural competence to diversity competence. And diversity sensitivity, which focuses on the recognition of different forms of diversity, and we heard one or two examples of that today again. Super diversity, the idea of diversity in diversity, being a normal reality for every individual, not just for migrants and refugees. And a comment about that whatever we choose to call it, there's much to be gained from this multidimensional perspective on diversity in terms of moving beyond the ethnic group as either the unit of analysis or the sole subject of study, and appreciating the coalescence of factors which condition people's lives. And intersectionality is the third element of this, consideration of the interconnected nature of multidimensional and overlapping factors, and the need to help caregivers and clinicians interact more effectively by understanding the complexity and multiplicity of each person's individual identity and how these intersect with one another. And so an intersectional approach is again important and requires a clear framework for which some tools are being developed. And there is in general a paucity in the literature in medical education, suggesting also and worrying some people who are concerned about these things that there is a risk that it might be understood in a superficial way and stopping at diversity and not going beyond that. So I think the next of these three things is an area which does require, first of all, better integration, a better understanding of the complementarity and overlaps of these three perspectives, which clearly are interconnected with one another, and from that developing something that might become broader standards that people can apply. Thank you very much.
Thank you very much, Stephen, and thank you very much to all the panelists for the excellent contributions. Now I would like to open the floor for questions. Please, we have some wonderful assistants in the room. I really ask if they can help us with the microphones around. I see one of the student assistants. Can you please help us with the microphones too? Thank you. We have mic. Yeah, there are also mics there, please. Yeah. And okay, yeah, if you can bring them to the people, it would be easy. Otherwise, people should stand, and I think it's easier if you can bring them to them. Yeah, thanks a lot. Thank you. If you can please say your name and institution, yes.
Thank you. My name is Stella Megwini. I'm from Monash University. I'm a biostatistician, but also into occupational health epidemiology. So my question is kind of to all the panelists. Thank you very much for your presentations. And you all kind of touched on things that were in my mind and the things that I'm hoping to work on. So I like that you've got programs that are supporting clinicians to work with refugees and support the migrants. But as an occupational health epidemiologist, I wonder whether you've got some programs that actually support the workers themselves. So I know a couple of you mentioned that you've created programs where, like, the Afghans go and support the Afghans. And I think you also mentioned something similar. But they also need support, because I've come across a few people who say that their work actually can make them remember some of their past experiences, and then that just affects their mental health once again. So I don't know if you've got anything that you have.
Please.
Thank you.
Thank you very much. That's very important. That's why in the curriculum, which is being somehow advocated by the WHO, there is a specific emphasis on some kind of cultural and somehow empowering the individuals themselves who have been suffering from these issues in the past as well. One particular example I can say is we have within our curriculum having the specific focus on identifying the specific needs of those healthcare providers from the Afghan community. And this happens when they begin to start, they begin their curriculum and they begin to have their studies, there's a survey. and there is a certain number of questions they need to answer. And then based on that, within their curriculum, and after that, there are services available to them if they want to somehow cope with the pressure and somehow cope with the past life that they have had in their own experiences as well. It's very important that specifically in the countries who somehow adopt the mainstream services, we have a very contextual, specific curriculum for those kind of characteristics of those community. One particular example is it absolutely differs when Afghan health provider provides healthcare services to Afghan refugees in the context of Tehran in Iran and in the context of Berlin in Germany. Actually, we have done a comparative study between Iran and Germany, a student of mine who works in the University of Bielefeld with Alexander Kramer, to see the different needs of Afghan refugees in Iran and Germany, and the needs for the training of Afghan healthcare workers in Iran and Germany. And expectedly, there are some fundamental differences, which goes back to the experiences of these people, the Afghan healthcare provider themselves, which goes back to the contextual specifications of that particular country that they are somehow living now, and their past experiences. So in general, yes, but still much work needs to be done in order to see how actually cultural past experiences, the mental health issues can be embedded in the curriculum for the training of the healthcare providers in order to provide the opportunity for them to cope with their own past because they are refugees themselves. And that's very important to consider.
Thank you. Amir, please.
I actually was going to say, we've also prompted the acknowledgement that the ways in which people come to work in our health system, particularly if you're a migrant and even a skilled migrant, are also deeply traumatising. And that is something that we are continuing to contend with within our College of Physicians, is how do we support making it easier for people to actualise the skills that they already had. Bearing in mind that only about 30% of overseas qualifications are even recognised here at the most basic level here. In the room next door, I overheard a conversation between two volunteers, one of whom is trained as a physiotherapist in another country and is now coming here to retrain to become something completely unrelated. What does that tell us about the level of waste that we are, very comfortable to accept when we have people who are fully capable of delivering work and filling some of the dire gaps that we have in our healthcare system, but we won't support them? So when we talk about what can we do to support people in the workplace, it's also how do we tackle some of those structural barriers for people flourishing and actually contributing to the work environment, including asking, as an advocacy piece, as healthcare workers and collaborators, asking for support to close some of the gender and also ethnic pay gaps that emerge when we have people with the same qualification doing the same job, one of whom were trained overseas and one of whom trained here, and they've got a distinct pay gap. And that is now established to the tune of, and I'll finish with this statistic because it horrified me, if you are somebody who is a recently arrived skilled migrant in Australia, there is a 10% pay gap between you and somebody who's doing the same job in the same organisation, and that amounts to essentially wage theft of $4 billion a year for that group. And that is where I think we need to start having those advocacy conversations that say, of course we want people to come into work here, but we also respect you enough to measure those sorts of numbers and to also feed back into the system that we are supporting, not only in kind, we're looking after your mental health, but we're also looking after you from an economic perspective and from a social determinants perspective. And we're committed to seeing that change because we value you. We value that you're wanting to build capacity. We value the contribution that you're making. So, excellent question. Thank you.
Thank you. Thank you, please, Michelle.
Thank you for that very important question. In our context, I know not only in my organization, but also partner organizations, we focus a lot on self-care, training of community health workers, but also from the point of onboarding at the time of recruitment. And also, as they continue to work, there are a range of support systems that they are advised about. There are regular check-ins, specifically for them, referrals. And in our budget, we also have a line item specifically for their care and support, which is much higher than what non-community health workers are given. There is also constant monitoring, so we are also doing, constant, especially for those who already might be having a problem. And then we have encountered 2 cases at least where they want to continue to do this community work because it's meaningful, but they are distressed with listening to stories of trauma, especially while translating. So what we do in instances like that is to change the job scope. So they could prepare some IEC materials or do something else and continue to be part of the team, but they don't have to continue to do work that distresses them.
Thank you. Thank you very much.
I was also just going to add one aspect of our recruitment is actually finding out what people's motivations for working in the space are. So the higher rates of vicarious trauma are usually associated with people who think coming into the space they can save people, or this is their humanitarian effort. So actually understanding what people's motivations for working in the space are really important in terms of that self-care and acknowledging that this is a place of empowerment. We're not working on another form of disadvantage or colonization where people are disadvantaged and saviors are coming into the space. So I think it's a big acknowledgement as a sector that needs to be more widespread, that there is one of the disadvantages is what are people's motivations for wanting to work with this population group. Another important aspect, I guess, and my colleagues have already shared on it, is also ensuring that people are being hired for the skills that match the job that they are required to do. So one of the dangers of some of the workforce and being, I'll speak to the Australian context where bicultural workers are called upon. During COVID, this was very common. People are called upon. We can't vaccinate people from a particular population group. Let's get people that are like for like. People were not given work phones, so there wasn't an opportunity for people to have a distinction between their personal life and the end of the work. So making sure that if people are going into a job, it is a job. They're given a work phone, a work email, they're remunerated appropriately for the work that they're doing, and acknowledging that intersectionality that was spoken around being part of a community and being in the workforce, there are some parts of my life that I can't separate. So you could be in the clinic doing your work. At the end of the day, if there's a funeral in the community, you still are a part of that community. But part of that is having supervisors and supports that are actually aware of the impact of intersectionality and lived experience of healthcare workers working in the space.
Perfect. Thank you. Thank you very much. I saw there were some other questions before. If the helpers, either you come to the microphone or the microphone will come to you. Okay, there are two possible solutions.
Thank you. My name is Irma. I'm an intensive care specialist here in Melbourne. Thank you for your excellent presentations. I am in so much awe of the work you guys do. Prevention is better than cure. As healthcare workers, we routinely speak out against smoking, gun violence, etc. So my question is, how do we build capacity and protection of healthcare workers to speak out against the conditions that lead to refugee crisis? By this I mean the plausible genocide in Gaza, the ongoing war in Ukraine, the persecution of the Rohingya, the drug wars around the world, and also many other conflicts that we may never remain aware of.
Thank you for the question. I don't know who would like to answer.
I can talk from my team's perspective. A lot of the work that we do, the data that we collect, feeds into the state and national policy agenda. So I guess as healthcare workers, our biggest arsenal is the data. So the more data we are collecting, the more documentation of the impact of the atrocities that you've listed in all of those, on the development of children, on the outcomes on people's health, the more we're able to advocate for better resourcing. Another important tool, I guess, that we use as workers in my service is adapting tools or screening tools that are already used in mainstream. For example, mental health screening tools are not standardized for refugee and migrant populations. So working on ensuring that if we're administering a K10, for example, which is a common mental health screening tool, how are we adapting it to ensure that we're capturing the data that speaks to the refugee and migrant experience? So I guess it's a two-pronged approach, the data collection, but also ensuring that we're actually using the science to justify the argument. So the more we are not using the screening tools and the competency standards, the more I think we're being silent contributors to the fact that those ongoing atrocities will continue.
Thank you. Please, Amir.
I have 2 points to add here. One is some people are advocating that refugees and migrant health should be within the curriculum of medical students. So in particular, the risk factors that this population have, not just in a specific part of the world like my country, which has a massive number of refugees, everywhere medical students and public health advocates needs to be trained in terms of refugees' health, and then they need to be aware of this, and then they can communicate this with the general community and refugees both. The second thing is, I think the entire world will be facing something which is called climate change refugees, people who will be migrating because of the climate change. And this applies to particular parts of the world, including my home country, because of the climate change and massive changes which brings, and people have to leave their home, first of all, home city, and then the home country because of this. And this is the reality of future if we don't do anything. For that particular time, we need to be aware and we need to be prepared in order to somehow face this reality. And for that, I guess, again, having this kind of preparation, national preparation, and including refugees and migrant health as a part of natural curriculum for healthcare professionals would be very, very essential in order to somehow prevent those kind of consequences.
Thank you, please. Yeah, you. Sure.
Yeah. So I have two of my colleagues sitting here, Mark Simmons and Asika Palanda, and we teach a module on refugee health in Monash. But I think that that is still not enough. Acknowledging that advocacy is a core competency for healthcare workers, especially in terms of mediating equity in health systems, there's definitely much more to be done. But I also just want to respond to a statement that you made. In a country like mine, it's easier to advocate on Gaza or another country. It's riskier for a healthcare worker to speak up for the rights of refugees and migrants within the country. And I alluded also to the issues of dual loyalty. And that's why, reflecting on the competency standards here, it's coming more to me that in addition to technical skills, we also need to look at building of capacity in terms of how do you navigate these ethical dilemmas. And I think we need to do it while they're already training as doctors and healthcare workers. And it's not enough to just give information or build skills. I think that because the situation is so adverse in certain countries, there is a need for more regional and international solidarity among healthcare workers, especially to support those in countries like this who are sticking their necks out and may even lose their practicing license in delivering healthcare to these populations.
Thank you. Please, Joachim.
Just a comment on prevention. Can we prevent people from leaving their country by improving their healthcare system in their own country? I don't know, but I hope this is the case, and that's why hospitals decide to do humanitarian work in countries where they have this particular problem, that healthcare systems are weak, that even healthcare workers flee from these countries. And we feel that our responsibility as a hospital in the middle of Europe, that we feel the responsibility to do humanitarian work in these countries. So that's why we do this work, for example, in one country in Africa, which has, in relation to its population, produced most refugees. And we also know from different healthcare workers in these countries that they've also left this country, even though we have worked with them together. So if this is I hope this can prevent something. It's a drop in the ocean, I know, but we keep on going to do also this work, not only in the Northern Hemisphere, but also in the South, in these countries. So at least there is, I feel also from our employees that they really do want to do that work, and also from students who want to contribute to that. And this is maybe a sort of prevention. Thank you.
Thank you. I just want to reinforce the point that education and training of the health professionals is not only about building their competency in the clinical setting, which we've talked a lot about, but it also needs to extend into building community awareness and community knowledge and community support, and also in the political arena for being stronger and more coherent voices, which needs to go right up to the top national and international levels.
Thank you very much. So unfortunately, the time is up, but we need to maybe have a final message from each of you in the same order, maybe 1 minute each to conclude the session. Please, Joachim.
I think I've given already my final message. Do support refugee in their home countries and go also to countries where they come from.
Thank you. Amir?
Yeah, I think being very context specific, what Stephen said, it's very crucial, having healthcare professionals who are the advocate of refugees and going to the community, preparing the community and preparing the political ladder to receive the refugees. And last is having the capacity of refugees themselves and thinking of mechanisms to train them and prepare them for providing healthcare services to refugees to overcome the barriers.
Thank you. Good side.
I think I'll come back again to that central tenet of assessment driving learning, and after you've left here is to remember and reflect for yourselves what is it that you've learnt through the experiences and the conversations you've had here around capacity building, and how do you turn that learning into a point of evaluation for the services you work, a point of evaluation for yourself and the systems that we work in, because there's no, I think one of my favourite saying is if you're not at the table, you're probably on the menu. Make sure that you are not on the menu and the people that you support are not on the menu.
Thank you.
So picking up on that phrase, think global, act local, it's very important for healthcare workers and their education to gain competency in terms of understanding that impact of global contexts on the delivery of healthcare and health outcomes of these populations, but also how they can adapt their learning to providing the best care.
Thank you. Shadza?
I think mine would be around language, just to be aware that you wouldn't want someone to speak to you in a language you don't understand. So apply it more in your clinical practice and ensure those around you are also working with interpreters and translators to ensure good healthcare.
Thank you, Stephen.
And I'd just like to return to the point that I made earlier about the importance and the challenge of trying to operationalize ethical principles, and that's an area that really needs working on.
Thank you very much. So it's 3:30. As Italian, I try to avoid. I don't like the reputation of Italians to be late, so I try to behave differently. So many thanks to Monash University, first of all, for having organized such a beautiful and really excellent meeting. Many thanks to all of you participants for having been with us. Many thanks to the panelists. And also, please, if you want to have any update, there is a special page of the M80 Alliance when you go to the website of the World Health Summit on migration and health. So there you can find all the documents that actually were mentioned in this session, some publications that you can download for free, and also what is happening next. Actually, the next session will be in Berlin. I know it's far away for some of you, but I hope some of you will fly also to Europe. In mid-October this year, we will have a session on the effect of climate change on migration and health. So I hope some of you will participate, and looking forward to being in touch with you also for some other collaboration. Thank you.